these are all the anti and these are all the pro. Anti-nociceptive things gets blocked so that these pro-nociceptive blocks those things. So it doesn't allow you to reach the nerves. These are all nerve endings out here. When they reach it, you get excessive firing of these nerves. And these depolarization of these nerves makes you be very symptomatic to everything. For example, in this case, they are pro. I think it's playing the same thing again. And here is a cold thermal receptor. Again, one more arm. We really do not know exactly what it does. A lot of our drops works on this. So this is what happens when there is an excess stimuli, air, when patients talking more, when somebody speaks loudly, patient says that my nerve fires. And this is what really happens in these conditions. So that each and every molecule there has a reason why it is there and what it does. So finally, this mouse is not working fully. Yeah, now it's working. So finally, if you really look at the treatment, you have to treat the cause. By doing this, it changes the autophagy mechanisms. A bunch of inflammatory molecules out there, which probably indirectly it can be treated. Otherwise, all we do is we treat this. But these factors, the pro and anti-nociceptives, is very difficult to treat because you don't have a drug which can actually block it. Your steroids don't work on it. Our cyclosporins don't work on it. None of those known drugs works on this. So what happens here is when you give a treatment, we just did this experiment out here in our lab. You just look at an MMP9 with this control, and when you treat it, inflammation just by its treatment, it stops, it reduces. There is some changes out here, so it means that there's a potential role of local vitamin drops in the future. And this is just with the treatment. You can see that in our case, the dendritic cells goes, the nerves becomes better, and there's some lot more change in how the nerves are nerves start functioning. Thank you.
Thanks very much, Rohit, and thank you for the path-breaking work that you and Narayan Netralaya are doing, in helping us guide us through this vitamin D and inflammation. Any questions on inflammation from the audience? Yes, ma'am.
The oral, if I remember right, this is from the sun waves. I think each spray is 3,000 units.
Okay.
Pardon? 1,000, but they say that you use twice a, yeah.
3 sprays.
Yeah, 3 sprays. So what happens is, see, what you are giving from a physician is close to 6 lakhs unit. So it's a good question because it's not the deficiency of a vitamin which is causing the disease. It's that the vitamin D receptors on your corneal cells are blunted. They're not working for some reason. So what we feel is when you use anything which is on a low dose, it never wakes up. It's like an optic neuritis. You give oral steroid, doesn't work. It has to be a bolus dose. A bolus dose, when you give a bolus dose, what happens is the vitamin D receptor starts activating. So you can use it for a maintenance dose once you reach it, but not as a treatment. That's my call on this. I don't know, but that's from a science angle. A bolus dose makes your vitamin D, that's called VDR, vitamin D receptors, that gets upregulated.
Okay. Thank you, sir.
Any other question to Dr. Rohit before he moves on? So currently, is there something that you would recommend in terms of dosing in case you have someone where you think there's a refractory dry eye and there is an inflammatory component?
What my physician gives is he gives 6 lakhs international unit intramuscularly, and then he sees them. I think there is 3 more doses spaced over a month, and then he maintains them at upper limit of normal.
Right.
And that is for people, I mean, like I said, you have to be very good with your physician. You have to tell him that these patients do not respond to your oral treatments. They're on sachet for a long time, just doesn't work. The reason is, what I just said, your vitamin D receptors only gets triggered off with the bolus dose.
And what serum levels would you define
upper
as?
Limit of 40.
Upper level of 40?
Yeah, because more you give, if the patient is predisposed to a renal stones, there is a chance that they may get a renal stones. And the active form of vitamin D which you are giving bypasses your whole metabolism. So again, there is a chance that it reaches it faster.
Any other questions? So thanks very much, Rohit.
Thank you, sir.
And thank you very much for being on this course with me. Thank you. So we're going to move on now to the next talk, which is going to be on hyperosmolarity.
So Dr. Vanathi referred to this, the role of osmoprotection basically. This all came about when we got drugs which had compatible solutes in them. And therefore, Rishi to tell us about the role of hyperosmolarity and osmoprotection.
Can we come on screen, please? Yes. So thank you so much, Quresh, and thank you everyone for being here. I'm happy to see a full hall. It's always a delight to being addressing a full hall. So Dr. Vanathi touched on this briefly when she was giving us her talk, and she talked about the osmoprotectants and the hyperosmolarity issue. So this was something that was introduced as a concept in 2007. So it's been 10 years now. And I think gradually even the drug manufacturers have started to understand the importance of the additions of certain elements in their products which would help us do this. So is it a myth or a reality, really, all this talk about osmoprotection and hyperosmolarity? So we know that there has been this paradigm shift, and that both hyperosmolarity and inflammation of the ocular surface have been added to the definition of dry eye. And this was the definition in which these were added. Of course, there have been more additions as of last year on the basis of homeostasis and the neural instability aspects. So we'll discuss those later. So we know that when the proportion of water to the solutes in both the tear film and inside the cell are the same, the system is said to be in an isotonic state. So this is how we would ideally hope our ocular surface cells to be. But when there is a loss of water, there is a shrinkage or a desiccation that happens as these cells become dehydrated. And when the tear film is healthy, it maintains a constant osmolarity. But when there is a dry eye, the quantity of water in the tear film goes down because of high evaporation or because there was an insufficient water in the first place. And because there is less water in the tear film, the concentration of the solutes such as sodium and potassium increases, and this raises the osmolarity, upsets the isotonic balance and between the tear film and the ocular cells. So this is how the healthy eye is. It's pretty much between a 296, 302 milliosmoles, which is the same as blood. But in dry eye disease, this value is generally higher than